Diabetes insipidus. The name itself evokes an image of relentless thirst, a body craving water it cannot hold. This rare disorder disrupts the delicate balance of water regulation, leading to excessive urination and insatiable thirst. But unlike its more familiar namesake, diabetes mellitus, diabetes insipidus stems not from sugar imbalance but from a hormone called vasopressin. Vasopressin, also known as antidiuretic hormone, ADH, plays a crucial role in concentrating urine and conserving water. When this hormone is deficient, or its signals are ignored, the body loses its ability to retain water effectively. This leads to the hallmark symptoms of diabetes insipidus: frequent urination, often exceeding 3 liters per day, and an unquenchable thirst that can dominate daily life. The vasopressin test is not a single procedure but a carefully orchestrated sequence of steps designed to assess the body's response to water deprivation and subsequent vasopressin administration. This test helps pinpoint the underlying cause of excessive urination and thirst, distinguishing between various forms of diabetes insipidus and other conditions with similar symptoms. The journey begins with a thorough evaluation of the patient's medical history and a physical examination. This initial assessment helps rule out other potential causes of excessive urination, such as uncontrolled diabetes mellitus or kidney disease. If diabetes insipidus is suspected, the vasopressin test is then employed to confirm the diagnosis and determine its specific type. The test typically takes place in a hospital setting under close medical supervision due to the potential risks associated with dehydration. Throughout the procedure, the patient's vital signs, urine output, and body weight are carefully monitored to ensure their safety and well-being. The information gathered during this test provides crucial insights into the body's response to water deprivation and vasopressin, guiding the diagnosis and management of diabetes insipidus. The first stage of the vasopressin test focuses on understanding the body's natural response to water deprivation. This controlled dehydration allows doctors to assess how well the kidneys concentrate urine in the absence of external water intake. The process begins in the morning with the patient emptying their bladder. For the next several hours, the patient is not allowed to drink any fluids. This period of water deprivation may seem daunting, but it is crucial for evaluating the body's ability to conserve water. Throughout this phase, urine samples are collected hourly and analyzed for volume, concentration, osmolality, and specific gravity. These measurements provide valuable clues about the kidney's ability to conserve water. As the hours pass, the body naturally tries to compensate for the lack of water intake. Thirst increases, urine output decreases, and the kidneys attempt to concentrate urine, making it more concentrated. However, in individuals with diabetes insipidus, this compensatory mechanism is impaired. Their urine output remains high, and the urine remains dilute, indicating a problem with water conservation. After a predetermined period of water deprivation, typically ranging from 4 to 8 hours, the second stage of the vasopressin test commences: the administration of synthetic vasopressin. This crucial step helps differentiate between the various types of diabetes insipidus based on the body's response to the hormone. Vasopressin can be administered either through an injection or a nasal spray. Once administered, urine samples continue to be collected and analyzed hourly for changes in volume, concentration, and specific gravity. These measurements are then compared to those obtained during the water deprivation phase, providing valuable insights into the underlying cause of the excessive urination. In individuals with central diabetes insipidus, or AVPD, the administration of vasopressin leads to a significant decrease in urine output and an increase in urine concentration. This positive response indicates that the kidneys are capable of responding to vasopressin, but lack the natural hormone due to a problem with its production or release in the brain. The vasopressin test plays a pivotal role in distinguishing between the two main types of diabetes insipidus: central diabetes insipidus, or AVPD, and nephrogenic diabetes insipidus, or AVPR. This differentiation is crucial as each type stems from a different underlying cause, requiring tailored treatment approaches. As mentioned earlier, AVPD arises from a deficiency of vasopressin, often due to damage to the hypothalamus or pituitary gland, the areas of the brain responsible for producing and releasing this vital hormone. In contrast, AVPR occurs when the kidneys become insensitive to vasopressin, rendering the hormone ineffective in regulating water balance. This insensitivity can be a side effect of certain medications or a result of genetic mutations affecting the kidney's ability to respond to vasopressin. The vasopressin test clearly delineates these two types. In AVPD, administering vasopressin elicits a positive response, with urine output decreasing and concentration increasing. This response confirms the kidney's ability to function correctly when provided with the missing hormone. Conversely, in AVPR, administering vasopressin yields minimal to no change in urine output or concentration. This lack of response indicates that the kidneys cannot respond to the hormone, highlighting a problem with their sensitivity to vasopressin. The vasopressin test, while seemingly simple in its concept, carries significant weight in the diagnosis and subsequent management of diabetes insipidus. By unraveling the complexities of water balance and pinpointing the root cause of excessive urination, this test provides a roadmap for navigating life with this chronic condition. For individuals diagnosed with AVPD, the treatment typically involves hormone replacement therapy. Synthetic vasopressin, available in the form of injections, nasal sprays, or oral tablets, effectively mimics the action of the naturally occurring hormone, helping to regulate urine output and alleviate excessive thirst. The dosage and frequency of administration are carefully tailored to each individual's needs, ensuring optimal symptom control and improved quality of life. Managing AVPR proves more challenging as it requires addressing the underlying cause of the kidney's insensitivity to vasopressin. If medication side effects are identified as the culprit, adjusting or discontinuing the offending drug may restore normal kidney function. In cases of genetic mutations or other irreversible kidney damage, the focus shifts towards managing symptoms and preventing complications. This may involve dietary modifications such as reducing salt intake and the use of diuretics to minimize water loss.